Dear friends, this is phacoemulsification of a white cataract. The main incision is being given at 11 o'clock. A side port incision is given at around 8 o'clock. This cataract is white, but it is not intumescent. A big air bubble is injected into the antechamber, and trypan blue dye is used to stain the anterior lens capsule. I prefer to inject the dye underneath an air bubble. Here it is. The dye stains the anterior lens capsule. Since the pupil was not dilated well, mid-dilated it was, so here it is, some adrenaline is injected into the antechamber. And now viscoelastic substance is injected into the antechamber. This is 2% hydroxypropyl methyl cellulose. Now we can see that the pupil has dilated to some extent. Another side port has been made at 1:30 o'clock. The anterior capsule is incised with the 26 gauge bent cystatum, and a Utrata forceps is used to make a CCC, continuous curvilinear capsular axis. This capsular axis revolutionized cataract surgery, and it was described first by Dr. Gimbel in the 80s. Hydrodissection is done, and the nucleus is mobilized a little bit. Viscoelastic substance is again injected into the antechamber. Now the tip of the phaco handpiece is introduced into the antechamber. Here it is. Now this is direct chop. The tip is embedded into the nucleus, and a chop is made like this. The nucleus is rotated, another chop, and this triangular piece is emulsified and aspirated. The nucleus is rotated and chopped at another place. At this time, the phaco power is 50, flow rate is 45, and vacuum is 450. The pupil is mid-dilated. At this time it is around 5 o'clock, but it is very much possible easily to do phacoemulsification with this much size of the pupil. At this time I can come out and inject some visco. It becomes easier, but anyway, sometimes I become lazy and I want to finish it at on go. That's it. The nucleus is removed as well as the epinucleus. Some cortical matter, some cortical fibers are covered by the iris. We can't see, but we can remove it by sweeping movements of this Simcoe cannula. Here it is. You can see that it's nicely coming. The cortical matters It's nicely coming. Yes. Go through the side port and remove the cortical matter from 10 o'clock, 9 o'clock, 8 o'clock. But I'm sure some cortical matter which is there at around 11:30 or 11:45 o'clock can't approach with the Simcoe cannula. So I'm taking bimanual irrigation aspiration and I'm removing the cortical matter which is there at 11:45 o'clock. Here it is. It is removed. This is, I'm checking whether it is removed or not. That's it. Now viscoelastic substance is injected into the antechamber and a hydrophobic aspheric acrylic intraocular lens is implanted in the capsular bag. The chopper guides the haptic of the IOL to go into the capsular bag. Now the viscoelastic substance is thoroughly washed out of the antechamber. I go behind the IOL and wash the viscoelastic substance, flush it out, aspirate whatever is needed. I don't want a post of a rise of intraocular pressure. That's my aim. This is some more irrigation and aspiration to remove visco with bimanual IA, and that's it. Thank you very much for watching. See you in the next video.